Okay. Good afternoon and welcome to the San Francisco Planning Commission and Health Commission joint hearing for Thursday, December 3rd, 2015. I'd like to remind members of the public that the commissions do not tolerate any disruptions or outbursts of any kind. Please silence any mobile devices that may sound off during these proceedings, and when speaking before the commission, if you care to, do state your name for the record. I'd like to take roll at this time for the Planning Commission. Commission President Fong.
Here.
Commission Vice President Wu.
Here.
Commissioner Antonini.
Present.
Commissioner Moore.
Here.
We expect Commissioner Johnson to be absent and Commissioner Hillis and Richards to arrive shortly. Go ahead.
Hi. For the Health Commission, Commissioner Chow.
Present.
Commissioner Pading.
Present.
Commissioner Karshmer.
Present.
Commissioner Sanchez.
Present.
And we are expecting Commissioner Singer.
Commissioners, you have one item on your special calendar today. Item 1, the California Pacific Medical Center Annual Compliance Statement Joint Informational Presentation.
Jonas, just for a second, Commissioner Chow and I would like to just take a second.
Yes, we would like to take a second just for a minute of remembrance for our colleagues in public health who were so devastated and injured and harmed in San Bernardino. So if we could have a moment of silence on their behalf, please.
Thank you.
Thank you.
Good morning, Presidents Chow and Fong and Commissioners. I'm Elizabeth Pearl, Planning Department staff. Today's item is an informational presentation on California Pacific Medical Center's compliance with their development agreement for the 2014 reporting period. And this is their second reporting period. At today's presentation, you will hear from city staff on CPMC's compliance with key components of the DA that are relevant for the 2014 reporting period.
You have to
Sorry.
speak louder.
All right. At today's presentation, you'll hear from city staff on CPMC's compliance with key components of the DA that are relevant for the 2014 reporting period, as well as some updates on their projected compliance in 2015. Following this hearing, the Directors of Planning and Public Health will determine whether CPMC is in compliance with their 2014 obligations and will issue findings to that effect. A third-party monitor will review the Director's findings and will inform the Board of Supervisors whether he agrees with the Director's determinations. Better? Okay. As you may recall, CPMC's development agreement to build 2 new hospitals and 3 new medical office buildings was signed by the mayor in July 2013. Construction for both the Cathedral Hill and St. Luke's hospitals is now well underway, and CPMC is on track. In fact, they're ahead of schedule to meet their commitment to open St. Luke's Hospital within 2 years of opening the Cathedral Hill Hospital. For the 2014 reporting period, there are 11 main action items up for compliance review as outlined here. My colleagues will go into many of these in greater detail. To respect your time, we're going to focus on the main topics of concern that have been raised by the public, and then we'll be available for questions if you'd like to have more detail. I would like to note that one reporting area, the First Source Hiring Program, has a reporting period that does not correspond to the calendar year. That makes it a little more complicated to compare their hiring record to the goals in the DA. But for the 2014 calendar year, CPMC has generally met or exceeded these goals. And in 2014, CPMC was required to make 7 payments, all of which they have paid. They're also up to date on their 2015 payments to date. I'll now turn it over to Greg Asai of OEWD.
Good morning. Good morning. Greg Asai with the Office of Economic and Workforce Development. And our office is responsible for overseeing the workforce provisions in the development agreement. So there's 2 different elements to it. As you'll see in the presentation, there are workforce requirements relative to the construction, and there's workforce requirements relative to the what we call end use or the permanent jobs at CPMC. So we'll start with construction. There's 4 different components to this, so I'll walk through each of the 4. So for this first one, you can see that the goal is 50% of entry-level positions hires for administrative and engineering candidates. And pleased to report that so far 100%, which is 11 of the candidates, have been hired through the workforce system. So when you see system referral, that speaks to candidates who've been referred through our office or our network of community-based organizations with whom we partner. All right, the second one is also administrative and engineering, relates to internships. So the goal in the development agreement is 50% will be filled through our system, and as you can see, we're currently at 64%, 16 out of 25. All right, the third one is 50% of new entry-level union apprentice candidates will be filled with system referrals who are also graduates of our City Build construction training program. So this is the one element that we're currently challenged on. We're at 40%, so 21 out of 52. This deficit is due to a citywide shortage, particularly in local apprentice iron workers in this booming construction sector right now. So we'll continue to be diligent about that. That being said, going to the final one, which is kind of the big number with the project when it relates to construction, and that deals with the percentage of trade hours for union journeymen and apprentices, and it will be 30% performed by San Francisco residents. So as you can see in the status part of this slide, that we're currently at 34% of work hours performed by San Francisco residents, so that's a good number. So just quickly, I know there's a lot of interest in what neighborhoods folks are coming from through our system to take advantage of these opportunities. So we have it broken down here with the largest percentages being 18%, that's 2 neighborhoods. We really go by zip code. It's a bit imprecise to talk about neighborhood, but by zip code, 94110 and 94124, both at 18% of the hires, or work hours, I should say. And then we can see 94112 at 16%, Viz Valley 94134 at 12%. So I think it's consistent with the kind of clients that we serve and the commitment to work with neighborhoods that tend to have higher poverty rates and higher unemployment. So that's construction. I'm going to move to the permanent jobs or the end-use jobs. And as was mentioned, the development agreement works on a program year or a hiring year, which is August through July. So we're going to report on that. And you'll see that the goal is 40% of entry-level positions must be filled with system referrals in each hiring year. And then after that it says, well, if they don't make the 40%, then whatever the deficit is for that hiring year then gets rolled over to the following year. So just as an example, if there were 100 hires in a year, 40 of those hires need to be through our system. If, let's say, they only had 30, the following year they still have that 40% requirement, but then that 10-person deficit gets rolled over, so that following year they need to do 40% plus 10 people. So that's kind of a nice feature of this development agreement is if in any year they're unsuccessful, then it rolls over to the next year. So just again to highlight in the development agreement, there's priority neighborhoods that are spelled out here. So Western Addition, Tenderloin, Mission, Soma, Outer Mission, Excelsior, Chinatown, and then the southeast neighborhoods, Bayview Hunters Point, Pochero Hill, Visitation Valley. So how did we do this last program year? Well, the 40% goal was attained in this August 2014 to July 2015 program year. So 41%, or 80 out of 196 positions were filled with our system referrals. And 74% of the hires, of the 80 hires, were from the priority neighborhoods that were spelled out in the development agreement and I just mentioned on the last slide. So there's a vast improvement over the first year. At the end of the first year, they had a 13 hire deficit. At the end of this program year 2, that hiring deficit was down to 11. I'm pleased to say that so far this year, so starting with August 2015 through October, the period at which we have data, CPMC has hired 30 of its 41 hires through our system, which is over 70%, and as such, that hiring deficit has now been eliminated, which is a very good work on everyone's behalf. So 2 more slides. So one is there is a feature that I just wanted to highlight, which is to advance our efforts of training folks and getting qualified candidates to CPMC. CPMC paid $3 million into a workforce fund that's administered by the San Francisco Foundation. Focus areas on barrier removal and job training. And I've listed at the end, there's 6 current grantees who are receiving funds through this project. Faces SF, Jewish Vocational Service, Mission Hiring Hall, Positive Resource Center, Self-Help for the Elderly, and Success Center. And there was some delay in getting the money out. So hopefully, these contracts had just started in the late spring, so hopefully we'll see even more system hires through these efforts here. So final slide. There's the goals around the hiring. Ultimately, in terms of compliance, what we have to look at is good faith efforts. And there were some initial failings in terms of the good faith efforts going back to the beginning of the project. So there was a failure to submit entry-level job notices until December. The project had started in August, and the hiring projections didn't come until April. Subsequent to that, so over the last year and a half, 2 years, there's been some market improvements, so we're now getting daily submittal of job notices. We've gotten each year on time the entry-level hiring projections. CPMC is providing monthly reports. The DA requires every 6 months. We're constantly in contact with CPMC through meetings, conference calls. They've done trainings of their hiring managers, which I think has paid dividends. And there's been rotating hiring events on what we call employer spotlights throughout priority neighborhoods. And then both CPMC and our office has dedicated staff to it as well. So with that, I'll finish my section and turn over to Colleen from DPH.
Thank you. Good morning, Commissioners. Colleen Chavla from the Department of Public Health. And before I begin, I'd like to say that Director Garcia has been asked to attend a meeting with the mayor regarding the announcement of the Department to End Homelessness. So she will be here as soon as she's able after that meeting has concluded. So this is a summary of the healthcare commitments that I'll detail in my portion of the report to you today. Baseline charity care, the new Medi-Cal beneficiaries, the Innovation Fund, integration of the medical staff, community benefits partnership, the agreement with Chinese Hospital, and culturally linguistically appropriate services, also known as class standard services. So I'll start with the baseline charity care. And for the next few slides, I'll detail CPMC's compliance with the healthcare elements in 2014. We recognize, though, that we're well into 2015, and there is progress to report on 2015 compliance status. But to separate last year's compliance, which is the subject of this presentation, with the progress toward compliance for the current year, I'll address the details of progress to date on my last slide. So for baseline charity care, there are 4 baseline charity care obligations, and the goal of these 4 obligations is to make sure that everything else that was related to healthcare in the development agreement was on top of what CPMC was already doing. So there were additional responsibilities for CPMC. So these 4 on this slide are meant to memorialize and keep in place the charity care commitments that CPMC was making at the time that it entered into the development agreement. So first on the unduplicated patients served. So there is a requirement that CPMC care for 30,445 unduplicated Medi-Cal or charity care patients. This number represents the average of the last 3 years of unduplicated charity care and Medi-Cal patients that CPMC served. And it was represents care to low-income individuals. Charity care is free care offered to low-income people who are uninsured or underinsured who do not have the ability to pay for those services. And Medi-Cal patients are those with the lowest income in our city, those who make about $16,000 a year or less for an individual. In 2014, CPMC fell short of meeting this requirement by 1,849 patients. The development agreement, though, allows CPMC to make this up in an adjacent year under the 2-year rolling average provision. That is, the average of any 2 years must be 30,445. CPMC exceeded its commitment in 2013 by 1,266 patients. However, that number is insufficient to cover the shortfall that it experienced in 2014. Therefore, CPMC must make up the difference in 2015. At the end of the presentation, I'll discuss CPMC's efforts to make up that difference. The second baseline charity care element is community benefit spending, and this is $8 million annually for community benefits to the poor and underserved. And CPMC exceeded this requirement and expended $14.6 million in 2014. The third element of baseline charity care is the hospital's charity care policy. Charity care policies outline the income and asset limits required to access free care at any hospital, and the policies remain the same as they were before implementation of the development agreement. And the final baseline charity care element is the Bayview Child Health Center. CPMC had been a longtime supporter of the Bayview Child Health Center, and in 2014 they transferred ownership of the center to South of Market Health Center, which is a nonprofit community-based clinic. Under the transfer, CPMC provided financial support through a $325,000 operations grant, which will continue for 4 additional years. They leased the former medical director to the South of Market Health Center through the end of 2015 to promote continuity of care. They transferred all of the assets of the center, estimated at $91,000 to the South of Market Health Center at no cost. And they invested $1 million in tenant improvements and remains the health center's partner to provide hospital care. On top of the 30,445 baseline charity commitment is the commitment to continue to participate in Medi-Cal managed care and to serve 5,400 new Medi-Cal managed care beneficiaries. CPMC continues to participate as a provider in the San Francisco Health Plan, one of the health plans providing Medi-Cal managed care in San Francisco. And prior to the development agreement, CPMC had responsibility for 14,850 Medi-Cal beneficiaries. Under the development agreement, they are required to add 5,400 to that for a total of 20,250 Medi-Cal managed care beneficiaries. Through its partnership with Northeast Medical Services, CPMC has accepted a total of 16,247 new Medi-Cal managed care beneficiaries, exceeding their requirement by 10,847. One element of the 5,400 new Medi-Cal managed care beneficiaries is the commitment to serve Tenderloin beneficiaries. So of the 5,400, 1,500 would need to come from a new partnership with a Tenderloin serving provider, should such a provider exist. During the time of this reporting period, there was no such Tenderloin provider, but there was progress made on this partnership in the current year, which I'll detail at the end of my presentation. In addition to the previously described healthcare commitments, CPMC also supported a Community Health Innovation Fund, which is held at the San Francisco Foundation. The Community Health Innovation Fund is an $8.6 million fund that is payments to which are made by CPMC over a 5-year period. Funding decisions for how the funds in the Innovation Fund will be expended are made by a group comprising the San Francisco Foundation, the Department of Public Health, and CPMC. $1.125 million was deposited into the account on time in 2014, and in 2014, the Innovation Fund itself awarded $2.1 almost million to for 3 different projects. It supported 8 community clinics to improve care coordination to reduce preventable hospitalizations, and it extended the Progress Foundation grant to increase their emergency mental health services capacity. This slide details 5 other provisions that are in the development agreement. The first is around the requirement to develop proposals to address the need for subacute care in San Francisco. When St. Luke's is rebuilt, it will eliminate the only subacute unit in San Francisco. The Health Commission and the Department of Public Health granted them an extension to December 31, 2015, and I'll talk a little bit more about why that extension was granted. They also are required to make a good faith effort to integrate the medical staffs among the hospitals to promote continuity of care and access among all hospitals. And in 2014, one additional medical group was integrated. That's the pediatric hospitalists, and it adds to 7 others that were previously integrated. The third requirement here is the Community Benefits Partnership participation. This is a group of community-based organizations, the health department, UC San Francisco, and all of the hospitals that promote better health in the community, and CPMC has continued to participate on its successor group called SFHIP, the Health Improvement Partnership. They are also required to maintain the relationship with Chinese Hospital in a manner that's consistent with the previous relationship, and they have done that. And then finally, they are required to provide services, culturally and linguistically appropriate services that meet federal standards at all of their hospitals. They have policies and procedures and metrics in place, and while they are compliant with the development agreement, there are concerns that remain about the extent of their compliance, which I'll detail in the next slide. So I just finished the review of CPMC's compliance on the healthcare obligations for 2014, and I wanted to remind the commissioners of the issues that were of concern to you in the 2013 review, and then also talk to you about the progress that was made in 2015 since the conclusion of the 2014 reporting year. So in 2013, to refresh your memory in your review of that report, you were concerned about the possible 2014 baseline commitment shortfall, and in fact, as I reported, there was a shortfall. You were concerned about the status of the Tenderloin Medi-Cal managed care provider. Where would there be a managed care partner for CPMC to partner with to meet the 1,500 Tenderloin Live commitment? You were concerned about the culturally and linguistically appropriate services that were offered by CPMC, particularly at the St. Luke's Diabetes Clinic, based on reports that had come in from the community. And you were also concerned about the reduction in skilled nursing facility beds. While the development agreement doesn't require any skilled nursing facility beds to be provided by CPMC, the Commission was concerned about CPMC's planned reduction of a total of 174 skilled nursing facility beds after the rebuild of its 2 new hospitals. And subacute beds are one type of skilled nursing facility bed. So, on to 2015, many of these concerns were borne out in the 2014 report that I just detailed. However, I'm pleased to be able to report to you that progress has been made on the majority of these issues in 2015. On the baseline charity care shortfall, as I noted earlier, in 2014, CPMC fell short of meeting the requirement by 1,849 patients. The development agreement allows CPMC to make this up over a 2-year rolling average. And again, because the 2013 overage was insufficient to make up the underage in 2014, that means that CPMC must make it up in 2015. So to help address this issue, CPMC and DPH met to discuss ways to increase their services for Medi-Cal and charity care patients, including increasing CPMC's partnership with their existing Medi-Cal provider, which is Northeast Medical Services, or NEMS. CPMC and DPH also designed a partnership to help address this shortfall in a way that would benefit CPMC to help them meet their goal, and to benefit DPH clients who are on long waiting lists for services. So DPH's San Francisco Health Network, our own healthcare delivery system, had patients on wait lists as long as 9 months for certain diagnostic services. To help DPH reduce its waiting list and to assist CPMC in meeting this obligation, CPMC and DPH devised a process to refer 1,400 DPH patients to CPMC for 2 types of diagnostics. 1,000 echocardiograms, those are a type of ultrasound test that look for abnormalities in the heart, and 400 pulmonary function tests, which is a group of tests that measure effectiveness of the lungs. Despite a high no-show rate of approximately 40% among our patients, CPMC provided these tests to about 400 DPH patients so far. As of last month, CPMC reported that it believed it was on track to meet the baseline charity care commitment, including the additional 1,849 lives it needs to satisfy the shortfall from last year. And despite this, CPMC has continuing the partnership with DPH to ensure that those 1,400 DPH patients originally committed will receive the services that they identified. Regarding the 1,500 Tenderloin Medi-Cal managed care lives, I'm pleased to report to you that on August 1st, 2015, NEMS and St. Anthony's Medical Clinic launched a partnership that provides a pathway for CPMC to meet this obligation. Specifically, NEMS, CPMC's existing partner, added St. Anthony's Medical Clinic to its existing Medi-Cal managed care network, for which CPMC is the hospital partner. The creation of this partnership prior to December 31st, 2015 prevents the expiration of this obligation and ensures that Medi-Cal managed care beneficiaries have access to a Tenderloin-based primary care provider and access to CPMC for needed acute care services. As of November 15th, 2015, 17 beneficiaries were enrolled in this new partnership. CPMC is obligated to remain open to this partnership for the remainder of the development agreement or until it reaches 1,500 participants, whichever is sooner. The partnership provides beneficiaries with a new choice when they choose or change their primary care provider. Beneficiaries may not be transferred to the new partnership without their consent, and thus increased enrollment will be reliant on outreach and education among Medi-Cal beneficiaries. The CPMC Innovation Fund has provided funding to St. Anthony's to support outreach and education to promote this new partnership and encourage enrollment. In addition, the fund will support infrastructure enhancements at St. Anthony's that will enable them to be a strong partner to NEMS and CPMC to serve Medi-Cal beneficiaries in the Tenderloin. As a provider that has not participated in Medi-Cal managed care before, St. Anthony's will have to build its billing and patient tracking infrastructure to comply with Medi-Cal requirements, so this funding from the Innovation Fund is critical. Regarding culturally and linguistically appropriate services, national standards on national class standards, culturally and linguistically appropriate services standards, are broad policy statements, and CPMC is in compliance with these national standards. However, the Health Commission, as I mentioned previously, the Health and Planning Commissions expressed as part of their 2013 annual compliance report review that they continue to have questions as to the cultural and linguistic appropriateness of services at CPMC, particularly at the St. Luke's Diabetes Clinic. As a result of that input, the Director of Health requested a two-part peer review of CPMC's adherence to class standards. One was to look at the hospital as a whole, and the second to look more closely at the St. Luke's Diabetes Clinic. In response to these concerns, CPMC formed an internal task force to review their current compliance status and opportunities for improvement, and secured an outside expert to advise them. CPMC indicated that it would share with DPH the outcome of that assessment, and so DPH put the peer review on hold pending the results of CPMC's own independent assessment. On September 30th, CPMC shared with DPH their class assessment, and our subject matter experts reviewed it. As a result of their findings, the Director of Health sent a follow-up letter to CPMC on November 17th requesting additional information for future reports for the hospital-wide assessment and indicating her desire to proceed with the peer review for the St. Luke's Diabetes Clinic. CPMC advised DPH that it would be meeting internally to develop a response to this letter, which we have not yet received. With regard to subacute care and the post-acute care project, as I noted in my memo to the Health Commission in April, the development agreement requires CPMC to work with DPH and other hospital operators to develop specific proposals providing subacute care services in San Francisco. The date for presenting this information to the Health Commission was extended to December 31 of 2015 in order to align this work with a related request by the Health Commission to look at the need for skilled nursing facility beds in response to closures both at St. Luke's, at CPMC and at Dignity Health. So in August 2015, DPH, CPMC, and Dignity launched the Post-Acute Care Project to address the Health Commission's concerns regarding the availability of skilled nursing care in San Francisco and to fulfill CPMC's obligation to develop proposals related to subacute care, which, as I mentioned, is a type of skilled nursing care. The scope of the Post-Acute Care Project is defined as subacute care, short and long-term skilled nursing care for San Francisco patients discharged from acute care hospitals to the community. CPMC contributed resources to support the design, research, analysis, facilitation, and community engagement for this project. The project identified three primary goals: to summarize relevant skilled nursing facility data, the current need, current utilization, future need, and future demand; to identify community-based alternatives to skilled nursing facility care, and to develop recommendations for the Health Commission to review. The work of the post-acute care project is currently wrapping up, and a final report will be calendared for the Health Commission at the earliest opportunity, which will likely be January or February of 2016. And then finally, I want to talk about the public dialogue on the service mix at CPMC hospitals. All but one of the points related to healthcare that was raised in the Coalition's letter of July 23rd and November 24th of this year were addressed in the memo that I sent to the Commission's just before Thanksgiving. One additional point that the Coalition highlighted relates to the public dialogue on the service mix at CPMC. In the 2013 compliance statement, the Planning Director and the Director of Health encouraged CPMC to establish opportunities for regular dialogue with the communities surrounding their new hospitals, especially during this critical phase of development. On August 31, CPMC held a St. Luke's campus community meeting. They invited community members to a planning session in advance to help shape the agenda for the August 31 meeting and committed to a future meeting in 6 to 9 months. DPH continues to believe that CPMC's communication with the community is critical to exchange information and ideas to build trust. DPH encourages CPMC to continue the dialogue started on August 31. That concludes the healthcare portion of my report, and at this point I'll turn it over to panel 11.
Pamela Levin, Deputy Director, Health Service System. I want to point out that Dr. Catherine Dodd, who's the Director of the Health Service System, was called to a meeting with the Pacific Group on Health, Pacific Business Group on Health, which is a policy group that aids the city in determining health rates and health benefits for the city. The development agreement provided for an actuarial assessment of the 2014 rate increases. This was delayed. In 2015, HSS has worked with the HSS actuary to identify key questions for an independent auditor to answer by examining the Oshpod hospital data. HSS will forward these questions in the next 2 weeks and request that CPMC suggest actuaries for HSS to review and agree upon. Thank you.
And just to wrap up, and thank you very much for your patience through the complex and disparate details of DA compliance. Staff believe that overall, despite the concerns noted by my colleagues, and particularly in the areas of charity care and culturally and linguistically appropriate services, that CPMC is making the required efforts to comply with the development agreement's provisions, that there's reason to believe that previous shortfalls are being addressed in the 2015 reporting year, and that there are positive trends toward compliance overall in 2015. Staff's recommendation to the Directors of Public Health and Planning will be to find CPMC in compliance for the 2014 reporting year that we're considering here. And with that, I'm going to introduce Mr. Jim Maksud from CPMC, and he's going to give you his presentation, and then we'll be ready for public comments and questions. Thank you.
Good morning, Commissioners, Presidents Chow and Fong, Director Ram. My name is Jim Maksud from Sutter Health CPMC. Thank you for your time this morning. We're pleased that all the hard work that's been going against this development agreement results in the assessment from staff of finding us in compliance for 2014. And the foresight of the creators of the development agreement to include the rolling metric on some of the more complicated aspects of the DA is proving to be very wise, especially in these first years as we get the processes in place to make sure we are doing the work we are asked to do. And in that spirit, what I'd like to show you here today is some of the detail about the work that's been going on in 2015. You've heard some of this information in the staff's presentations. But we think it's important to go through. Regarding healthcare commitments, we've been working very hard. This central commitment of baseline health care is very important to us. And the shortfall that we expected to have in 2014, we reported to you in 13 and at an update hearing in 14, and we did in fact have that shortfall. So we've been working very hard against making up that commitment. And as you heard staff describe, in 2015, we've put programs in place, the diagnostic services at San Francisco General, the ancillary services in partnership with NEMS, and then we've also been providing services through events at Project Homeless Connect. We very much are committed to making this aspect of compliance be something that we do not have a shortfall on in any given year, and we're very proud of all the work that's happened in 2015 so that we've been able to make up the gap from 14. Also, as was mentioned, working with NEMS, we're 12,000 lives over the managed care enrollment commitment, and there has been a partnership developed between NEMS, St. Anthony's Medical Clinic to serve the Tenderloin patients. If you know our Director of Community Benefit, Emily Webb, her leadership on these issues, working together with the Department of Public Health and our partners, has been key, and in no short measure the reason why we're able to provide these outstanding results to you today. As was mentioned too, we have started our comprehensive audit of class services at CPMC, and we've shared that information with the Department of Public Health. I think you've all also received a copy of that report, and we're happy to continue working with them to make sure that as we continue the process and go through the next phases of our program, that it's done to meet the needs and expectations not only of the development agreement, but in the spirit of the development agreement and the expectations of the Department of Public Health. And was mentioned, we funded the Healthcare Innovation Fund with $4.6 million. Regarding operational hiring, you also heard this information from staff, but again, we are very excited to share this information with you today. There are significant challenges as this program got underway, and in the first few years, just trying to pull that process together and coordinate the pieces of the program with our hiring practices, it took some time, but we've put a tremendous amount of effort into that. We've hired additional staff, and you saw in the presentation the litany of activities that we're doing, whether it's training or job fairs, and the results of that you can see in the chart here. In the first couple reporting periods, we were behind or just barely getting to our goal. But if you look at August 2015 through October 2015, 30 hires, 73% of our local hiring, our hiring is now coming from First Source. That's tremendous. We're very, very proud of that number. We hope that that continues. Some of these challenges in a very competitive marketplace with low unemployment rates are going to continue through the life of this agreement, but we think that we've now really hit a stride with this program and that we'll continue this high rate. We're also very pleased to report that over 70% of those hires are coming from the targeted neighborhoods identified in the DA. Additional accomplishments from the development agreement, as you heard, we've not only initiated community discussion at the St. Luke's campus, but we've had community engagement at all of our campuses. And while I know there are always going to be members of the community who we might not meet their expectation for what that level of communication is, I think it's fair to say that they certainly know how to reach us, and that's a good thing. We've been a part of these communities for over 150 years, and we want this dialogue with them, so we will continue that dialogue on all 4 of our campuses. It's very important to us. We have hired additional full-time staff to work on the transportation management programs. We've conducted assessments at each campus. We have completed part of our process, I think, as we've described to you previously, was that we needed to hire this manager. They needed to come in and do some baseline data collection. We've done that. We've conducted the employee commute survey, and we're currently reviewing the scope of our campus-wide shuttle program. With construction workforce hiring goals, nearly $30 million has been invested into San Francisco contractors and professional services to date, an astounding number. And as you heard, all of our 2014 cash commitments have been made, and our 2015 cash commitments actually have been made ahead of schedule relating to these numbers that you see here. So in conclusion, we are very happy to have been found in compliance for calendar year 2014 on, or DA year 2014 on all commitments, and we're even more pleased at the progress we're making through 2015 and expect that, hope we'll be finding compliance when we get to the 2015 reporting year. I have just a few more slides for you here. This is a current view. This was taken yesterday from Van Ness and Geary. We are happy to report that the closures of Van Ness to do the work in the tunnel underground, they're done. They were done without incident. We're very pleased and happy about that. If you can see in the lower left-hand corner that big hole where the medical office building is going to go, that work is well underway. So if you haven't been by the site in some amount of time, it's worth seeing. It's very impressive as that steel comes out of the ground and the building takes shape. You're welcome to come by anytime. We're happy to have you there. And in fact, next week we're having a topping out ceremony to honor the workers and the progress they'll make to raise that last steel beam. Equally as impressive is our St. Luke's campus. This too was taken yesterday. The work here, as has been noted, is all on schedule. We had our topping out there actually 2 weeks ago. It was a wonderful celebration between the workers, our staff, and the community. And again, we'd be happy to have you there anytime. That's an equally impressive structure. Thank you very much.
Commissioners, before we accept general public comment, we did allow for organized opposition, a 10-minute presentation.
Yes.
Good morning, Commissioners. My name is Gordon Marr, and I'm here with San Franciscans for Healthcare, Housing, Jobs, and Justice. I'm also the Executive Director of Jobs with Justice, which is a member organization of the Coalition. Thank you for holding this important hearing, which is a key part of the public process to ensure that Sutter CPMC is meeting all of the important community commitments that it agreed to when it received approval for its hospital development plan back in 2013. For over 5 years, our coalition has worked to ensure that CPMC's reconfiguration of its San Francisco campuses serves the interests of patients, workers, neighboring communities, and the city as a whole. We played a key role in shaping the terms of the development agreement, and we've closely monitored the city's and CPMC's implementation of the DA. And we're here again this morning to offer our assessment as a diverse coalition, including neighborhood residents and leaders, nurses and doctors, and community activists and organizers. As detailed in our coalition's 2 comment letters, which you have copies of, we have serious, significant concerns about CPMC's failure to comply with a number of key substantive areas of the development agreement, which my colleagues will address in their comments. I will focus first on our coalition's strong procedural concerns about the city report. The coalition is deeply troubled by the extensive delay in its preparation and posting, which was 54 days later than specified in the DA, and resulted in a shortened time for the public, including our coalition, to digest and respond. We had only 30 days rather than 60 days as required by the DA from when the city report was released until this hearing. And it was only yesterday afternoon actually, that missing lines from key pages of the city report were reinserted and published. So it's hard not to interpret those failures as a city asleep at the switch and uninterested in public dialogue and full compliance. This year's city report is a significant step back from last year's, which was completed on time, responded to issues by the coalition, and did so a full 60 days before the joint hearing of the commissions. Despite the coalition's track record in identifying the key issues subsequently addressed in the Planning and Health Director's finding letter and in third-party monitor Lou Gerardo's letter to the Board of Supervisors last year, this year's city report chose not to engage in the dialogue that our coalition has sought to foster. Your commissions, the vulnerable communities most affected, and the public deserve better. We deserve city oversight that pushes CPMC to explain why it falls short and how it intends to make amends, that comments explicitly on the adequacy of CPMC's explanations and plans, and does everything necessary to ensure that CPMC promises of healthcare, jobs, and other public benefits reach the communities intended to be served.
Good morning, Commissioners. My name is Bob Prentice. We're running a little behind. I'll have to be really fast. From its inception, our coalition has attempted to ensure that CPMC's new hospitals contribute to a healthcare system that serves all people in San Francisco. Our concern was underscored by a December 2011 report from the UC Hastings College of the Law that documented while CPMC was the most profitable among private hospitals in San Francisco, it also had the poorest record on charity care. That's why, using leverage from the land use approval process, we advocated for specific commitments in the development agreement that would require CPMC to provide their fair share of healthcare services to low-income and uninsured San Franciscans. We therefore are disappointed to learn that CPMC has failed to meet its charity care baseline obligation for 2014. We understand that the Department of Public Health has worked with CPMC so they could provide diagnostic services for San Francisco Health Network patients to help reach their target. While it's good to help reduce waiting times for diagnostic services, it's far short of providing comprehensive health care to low-income and uninsured patients. We therefore urge the Department of Public Health to work with CPMC and community organizations to extend the reach of CPMC's capacity to serve low-income and uninsured San Franciscans. It was encouraging that Northeast Medical Service and St. Anthony's Clinic reached an agreement that would enable CPMC to meet its commitment to serving 1,500 new Medi-Cal beneficiaries in the Tenderloin. However, it was disappointing to learn that only 17 patients had enrolled as of November 15th. We understand that the option will be more appealing once the new hospital in Van Ness is open, but in the meantime, we urge CPMC, St. Anthony's, and the Department of Public Health to work with Tenderloin-based community organizations to better inform residents about their health care options. There's a common theme here. There are untapped community resources that can help CPMC in its planning and ability to meet its commitments. The Department of Public Health report cited a meeting on August 31st as the beginnings of a community dialogue process. The report neglected to mention, however, that there were 7 people from the community at that meeting. That's not a community dialogue. It requires a deeper, more substantive and sustained dialogue with the people who will rely on CPMC hospitals for their health care. Our coalition is willing to help facilitate that process. Finally, as a more general comment, it's especially important to engage the community in design of the new St. Luke's. While we are pleased that the configuration of the 2 hospitals is much closer to what the coalition had advocated for than what CPMC initially proposed, we also realize that CPMC's decision was influenced in part by the recognition of the changes in the South of Market neighborhood. We understand that St. Luke's Hospital will serve what Mr. Cohill famously stated at a Board of Supervisors hearing, a new demographic that's better employed and better educated. But it's essential that St. Luke's continue to serve the populations that relied on it historically. The new St. Luke's must serve everyone rather than becoming another force for gentrification. Thank you.
Morning. My name is Jane Sandoval. I'm a staff nurse at St. Luke's Hospital. I've been a nurse for 30 years at St. Luke's. Thanks for the opportunity to speak on behalf of St. Luke's Hospital and the community. As we speak, the rebuild for St. Luke's has progressed well. We already spoke about it's taking shape. And several weeks ago, there was a reference to the topping ceremony at St. Luke's, and it had all the bells and the whistles and the fanfare commemorating the rebuild. I just find this really ironic, considering CPMC initially had no intention of rebuilding St. Luke's, and the very coalitions that helped save St. Luke's weren't invited to the ceremony. But moving forward, I'm thankful for the rebuild. It's a reality. I see the construction every day when I come to work, and I'm hopeful for the future. But I do have concerns. I'm concerned about CPMC's track record. The track record for providing charity care has historically been lackluster. I appreciate that they say that they've been moving forward, but it still falls short. Historically and currently, St. Luke's has proudly served an underserved and marginalized community. I'm concerned that St. Luke's mission to serve the underserved will be in jeopardy as the gentrification is altering the demographic. The underserved continue to struggle for access to services and care, and CPMC has expressed a desire to attract the affluent with the comments of wanting to attract the better insured and the better educated. There's no plans for a pediatric unit at the St. Luke's, at the new St. Luke's. Hospitalized children will continue to have to travel to the Cathedral Health site, causing travel hardships to families who reside in the St. Luke's area. Many of the underserved depend on public transportation. In addition, the Diabetes Center, which has been addressed in the previous speakers, the Spanish-speaking nurse who was employed by CPMC Sutter has since then been dismissed and placed with a non-Spanish-speaking nurse. And I know anyone who's an employee of CPMC campuses and have used the translator phone, how inept that is, and that's not the same as a face-to-face as speaking with a patient without a translator phone. It will be a challenge for pregnant, Spanish-speaking, low-income women to access these services. Diabetes and pregnancy is common in the lower-income demographic south of Market. Once again, I wanted to nuance that I don't see any ironclad plans for psychiatric beds, subacute or skilled nursing beds. I see that there's ongoing assessments, but we need some ironclad plans because these people require care too, and that's part of the underserved demographic that St. Luke serves. Thank you.
My name is Ken Barnes, and I was a doctor at St. Luke's for 32 years. I want to address two issues: the mix of services at the new St. Luke's and the situation in the Diabetes Center. SFH2J2 believes that now the main battleground is the configuration of services to be provided at the new hospital, and will they serve all who use the hospital. The development agreement of 2013 called on CPMC to establish, operate, and maintain centers of excellence in community and senior health. CPMC's interpretation is to limit these centers to a small subset of 500 patients served by the St. Luke's Neighborhood Clinic. When I think of centers of excellence, I think of something grand and substantial, something that shows commitment to improving the health and quality of life of significant numbers of people, something that addresses health disparities.
Thank you, sir. Your time is up. Your group's time is up.
Can I take my own time and finish, please?
Well, your time was wrapped up as part of the group, sir, so I don't think that would be fair.
Well, I was going to go and I would like to be able to finish what I have to say.
We've allotted a 10-minute group opposition. That is your personal opportunity to be part of that group to offer public comment. If you want to have somebody else finish your thoughts or submit what you have in writing, that'd probably be best.
That disappoints me.
Okay, opening it up to public comment. Calvin Welsh, Avani DeCini, Ken Barnes, Tess Wellborn, and Marilyn Morgan.
Okay, my name isn't on there. My name is Melanie Grossman, and so I will get to the back of the line. And
that's right.
I can go. Okay, This is short. Good morning. So my name is Melanie Grossman, and I am a licensed clinical social worker, and I'm also a member of the Older Women's League of San Francisco. And the Older Women's League is very concerned about the health care needs of seniors all over the city, but especially in the St. Luke's community. Many of our members belong to those neighborhoods, and we are concerned that the continuum of care for seniors would too often require them to go to the Van Ness campuses, making preventive care, acute care, and aftercare more difficult. Transportation is one of the greatest challenges for people as they age, and all shuttles and things like that are very stressful for people who are disabled, and we feel that St. Luke's should provide care for their community members in the community. So with that said, I think we should have a special concern for our seniors who are in the St. Luke's area. Thank you.
Calvin Welch, San Franciscans for Housing, Healthcare, Jobs, and Justice. I would simply like to point out a couple of, it seems to me, very important facts that have not been placed before you in sufficient emphasis, in my view, by your staff. One, of course, is the slippage in the reporting and outreach around the reporting of the compliance of this compliance hearing by the planning department staff. That does not indicate a department leaning forward, involved in ensuring community participation, which is a little bit distressful since, as has been stated correctly, significant aspects of the development agreement were due to the advocacy of community-based organizations, principally HHJJ. Secondly, it seems odd that the staff is so willing to urge you to believe that there is compliance when at least in 3 areas there's been compliance only because of the quote-unquote rolling 2-year averages. This is an odd definition of compliance. Compliance means that we're not complying this year, but we promise to comply next year. And that is basically the case in every area except employment. Employment, there has been significant increases both on the city side and on CPM side, for which we are more than happy. We're gratified to realize that strong advocacy by our member organizations has produced that, which leads me to my conclusion. There is a requirement, it seems to me, in the history of this project in building in institutionally community involvement. And that is available to you by amending the development agreement to include collateral agreements with organizations like our coalition to ensure around the critical issues of healthcare and healthcare planning and continued advances in employment, that community voices and advocates are heard, which it seems to me are pretty clear are the driving force of all of the benefits of this development agreement. Thank you.
Good afternoon, Commissioners. My name is Layla, and I'm with San Franciscans for Healthcare, Housing, Jobs, and Justice. So I'm going to dedicate my time to addressing the workforce commitments made by CPMC, or the progress on these workforce commitments. So as you heard from OEWD earlier, in hiring year 1, CPMC hired 6 candidates out of 47 total hires from the first source system, which was a total of 13%, grossly short of the 40% goal. So in hiring year 2, after significant public advocacy from our coalition and other parties, hiring greatly improved. 80 out of 196 candidates were hired through the first source system. OEWD also began sending over monthly hiring reports, and our collaboration and monitoring improved. So we are greatly heartened to see the success of community advocacy efforts along with city oversight to ensure members of our local disadvantaged communities are hired. Furthermore, we are glad to hear of the strong start to hiring year 3 from August to October of this year. and the filling of the hiring shortfall from past years. No one is more pleased than our coalition, who advocated for the strongest possible hiring commitments and have continually monitored and pushed for full compliance over the past 2 years. We hope that this level of effort and oversight can also be similarly applied to CPMC's healthcare commitments. We remain concerned, however, that there are key target neighborhoods that have been woefully underhired from, and these include the Tenderloin, Chinatown, Viz Valley, and Soma. Hires from these neighborhoods account for less than 20% of total system hires, and we urge greater attention to hiring in these critical, underserved communities. Finally, we are concerned about retention rates among candidates hired through FirstSource. We do urge stronger attention to retaining the workers hired into entry-level positions so we can see a sustained commitment to them and to their communities. Thank you.
Good morning, Commissioners. Tess Wellborn. The Coalition has pointed out a number of deficits, and I definitely am concerned about all of those. And I urge you to say that CPMC has not been in compliance because of these significant areas. Charity care shortfall, the Tenderloin has been underserved, and that means a year or 2 years of lack of health care there, and with serious needs. The lack of hiring for both construction and non-construction people, the shortfalls there, and the lack of getting the actuary to look at service fee increases. So much good work has been done by CPMC, but please do not certify this, do not pass this until their completion of all of these matters. Thank you.
Hello, Marlene Morgan, Cathedral Hill Neighbors Association and the Coalition for Housing, Jobs, and Justice. First of all, I want to thank Mr. Maqsood for his comments about community engagement around Cathedral Hill Hospital, and also Mick Penn, who is the construction manager for Herrera Bolt, an outstanding organization. We have had great construction management at Cathedral Hill. We also have had great community engagement. One of the things that I like the most about the construction management agreement, in addition to all the work they're doing around safely demolishing and constructing the hospital, is they have a commitment to shuttling and getting their employees, all of their workers, into this congested area without all of them driving in and parking their personal cars. That's a big accomplishment for the construction workers, and one that is missing for the rest of the 6,000 employees employed by CPMC. At the time that we started this conversation in 2005, the biggest private employer in San Francisco. So from all of the conversations that we had for many, many years, the community has strongly said we need to get people to have alternative forms of transportation to come to work at CPMC because they can't drive their personal cars and park. One of the things that CPMC did commit to in the development agreement was to do the transportation demand management program. However, there has been an interpretation recently that doesn't have to apply till 2020. So as we can see, when we started in 2005, 55% of their employees lived in San Francisco. 2013, the date of the DA, 45%. I would project with increasing affordability issues for employees, we're going to get down to maybe 70% or 80% of these people by the time this hospital is opened that are commuting in from outer suburbs. We have to get people out of their cars. Cathedral Hill is an urban hospital. It generates over 20,000 trips a day. It has over 3,000 employees. There is no employee parking. We must urge CPMC to be a good corporate citizen and put in the transportation demand program now. I would love to see them step up and do a great job with that, like they're doing with their construction management, be a corporate hero, and help out with the transportation access for their employees, their current and their future employees, effective today. Thank you.
I want you to ask me to stop. No, I'm just kidding. Good afternoon. Good morning, commissioners. My name is Asha Safai. I come as a resident of the Excelsior in the southeast part of the city. I was part of the Citizens Advisory Committee back in 2008, 2007, when this conversation began, and it was really about, at least from the perspective of our part of town, was about rebuilding St. Luke's Hospital. But it wasn't just about rebuilding a hospital. It was rebuilding a hospital with culturally competent services and the services that were really going to serve our part of town. I'd like to echo some of the things that the lady from the nurses got up and said. It's really, really important. As a father, as someone that has 2 young children, and I know many of you have children up there and have gone through this process, the idea that you would move the pediatrics inpatient from St. Luke's all the way to Cathedral Hill is anxiety-provoking, and it's a burden to those families, and it's not keeping in the spirit of what we've discussed in this development agreement over the last 7 or 8 years. The idea that you would fire Spanish-speaking nurse or clerks in the diabetes unit when there's a lot of families that are dealing with pediatric diabetes, this is a serious concern. It's a concern for members of our community. And then one of the other things is a lot of the primary and preventative care for seniors. Our part of town, particularly out in the Excelsior, Outer Mission, that area of the city, has a lot of elderly aging in place. And a lot of them can't rely on family members to come drive them, as the lady said, cross town. And so they rely on public transportation. So to get from, just to give you guys a cross street, Mission and Silver, all the way to Cathedral Hill in rush hour, that's over an hour plus travel on public transportation. It's not realistic. It's not meeting the spirit of what we talked about in our development agreement. So I urge you today not to certify this and force them to do more work to meet the demands of the community, community-based organizations, and be more culturally competent, specifically at St. Luke's Hospital. Thank you.
Sir, again, when your organization requests to speak as a group,
I'm speaking
but
as
you
a
are
resident.
also part. You can't speak under both organized opposition and a member of the public. You have to come in and speak as
I
one.
have some information that I think is very important for the commission to hear. And
You can submit that in writing, sir.
I would like to state it right here. I mean, really, you want to hear from the community.
I think in the future, your organization is better served not to request formally to be recognized as organized opposition and come and speak as individuals. That way, your time is reduced by 1 minute, but every person is then entitled to speak for 3 minutes, so that someone else doesn't take 5 minutes and eat up your 3 minutes or whatever part of that portion of the time allotment was.
Well, I take that under
I mean, this was a
advisement.
choice that was made by your organization.
But I'm now speaking as a resident and a person who uses St. Luke's. So I would like to just make some brief comments about the Diabetes Center.
Sir, it is possible for a commissioner or any of these commissioners to call you back to the podium to express your thoughts. So that is a possibility which still remains.
So after public comment
yes.
finishes, we're going to open it up to commissioner questions, deliberations, comments.
And we can
at that time,
call you back.
A commissioner may or may not call upon anyone in the public to offer a comment, clarify something. We can do the same with staff.
It's an equity issue, sir. If we recognize you, we have to allow the recognition of anyone else who spoke in your group to come up and be provided full 3 minutes again.
Okay. David, please ask me to come up afterward.
Good morning, Commissioners. My name is Avni Desai, and I am the new Public Policy Manager at the Community Housing Partnership and a part of the coalition. Our mission is to help secure housing for the homeless and help lead our tenants to self-sufficiency. Last year alone, we served 1,500 people. Among those 1,500, many are seniors, people with disabilities, families, and other folks who need access to quality, affordable health care. We believe that good health is not just a privilege, but an absolute right for all our residents and for everyone in the Tenderloin. This includes proximity access to health care, and for that matter, I ask and urge you today to call to action our Department of Public Health and CPMC to reach out to our Tenderloin residents and let them know their options to obtain quality, accessible care. Let's start the dialogue with the community. Healthcare access for CHP residents and Tenderloin residents is imperative, so let's ensure that our residents benefit from the care CPMC has the potential to provide. Thank you.
Good morning, Commissioners. My name is Fernando Martí with the Council of Community Housing Organizations and a member of the San Franciscans for Healthcare, Housing, Jobs, and Justice. As a coalition of community housing organizations, we are committed to serving the communities that we are in and to engaging those communities in the work that we do. Several issues have been raised earlier, and I just want to reiterate a few of them about the lack of community engagement as we are moving forward through the development agreement. Primarily, or to begin with, as you heard, procedurally, the lateness and the short response time severely limited the ability of the community to respond to the development agreement. But more specifically, around the issues that have been raised around cultural competency and the mix of services within the hospitals as they are being developed. As you heard, getting rid of Spanish-speaking nurses, being replaced by diminishing services through a translator phone that might fit some abstract listing of what cultural competency might be. Well, I lost something there. But far less than what was being provided as is. But more troubling is the lack of community engagement in developing that service mix in both of the hospitals. And as one of the speakers said before, moving, for example, pediatric care from one hospital that serves the southeast of San Francisco up to the north is very troubling. So what I want to do is just reiterate what speakers have said so far from our coalition. We ask that you not certify this report, that you read carefully the comments and suggestions that have been raised by San Franciscans for Healthcare, Housing, Jobs, and Justice, and take those into consideration before any certification. Thank you very much.
Okay, is there any additional public comment? Oh, sorry. Any additional public comment? Okay, public comment is closed and opening up to commissioners. Commissioner Antonini.
Yeah, I have comments, and first I have some questions. I'd like a representative from Cal Pacific maybe to answer some of the questions, whoever wants to. My first question is, I believe the DA does allow for a rolling compliance. It was what was already put into the development agreement. Is that correct? Yeah. Oh, thank you. You may want to come to the microphone, sir, because I have a couple of other questions. Yeah, so this should not be a surprise, and it's only realistic, and I'll have some reasons why it's realistic in a minute, but I want to ask questions first. The next question has to do with, I think I heard from the report that the St. Anthony Clinic and the Tenderloin outreach efforts will be part of a report that will be finished by the end of this calendar year. Is that correct? Did I hear that?
Yes.
Okay, so that we would assume that that shall be clearly addressed in next year's report.
That's correct.
Okay, so that was a question that was raised. The other question, there's a little confusion. People were talking about senior care and pediatric care, but I think outpatient care for both those groups will still take place at St. Luke's.
That's correct.
But the hospitalization, particularly maybe pediatric, would probably be centered in the Cathedral Hill Hospital.
That's correct.
And pediatric for everyone else, including all the people that come from throughout San Francisco and the third of your hospital population that come from outside of San Francisco. So it's the same for everybody.
That's correct.
And this is hospitalization is a big difference. I also understand you have a specialty area of focusing on liver care in St. Luke's, and you'll continue to have that?
Correct.
I have a patient who is one of the physicians who is involved with that, and that is where you are sent particularly for liver-related problems and diseases.
Yes.
Okay. And then the same with, let's see, I think those are most of my questions. I didn't have too many others, but thank you. Have a few comments. Yeah, I think that the report is very promising, and it looks to me as if all of the hiring goals, as well as most of the charitable goals, are either satisfied by the end of 2014 or have been reached or exceeded to date in 2015. So that's, you know, what we want to see. I think there is a need to have the 2015 report at an earlier time, and part of this might be something we have to talk to the city about and make sure that it comes out at a more realistic time, like mid-year or sometime. There is apparently a time when we're supposed to have the report, and we are a little late this year, so that would be helpful for next year. And yeah, as I pointed out before, one of the reasons that, you know, the compliance does have to be rolling on some of these things is hiring for people in acute care situations in hospitals takes training first. So even with the best of intentions, you have to have special training to be able to be to serve in certain capacities as a permanent employee in an acute hospital. And so I can see where it takes a year or two to get up to speed and maybe to acquaint people that need training to be able to work effectively in these situations. And so that, and I noticed that St. Luke's topped off first, which is encouraging to see that it's finished its steel work even before Cathedral Hill. And yeah, I think it's great to see that this is a hospital that has lots of excellence and attracts people not just from San Francisco, but from outside San Francisco. I have a number of dental patients that live in Marin County, and I think almost without fail, when they had children, the children were born at Cal Pacific. I think more people from Marin have their children born in Cal Pacific than are born in hospitals in Marin. I'm not sure of the statistics, but, you know, because of their excellence. And this is something I think is great. San Francisco has always been a center from which people come throughout the Bay Area, and because of the excellence of the hospitals we have in San Francisco, and this is continues the thing. And in terms of where you go for care, I'm a Kaiser member, and I have to go to places like Redwood City, Sacramento, South San Francisco, and Marin for different services. So, and those are just outpatient services. For hospitalization, you know, the same thing would apply. There's a difference between the two, and it would be nice. It's probably not the most effective thing to have all services having hospitalization in 3 different hospitals when you can put all your staff together and deliver the highest standard of care, particularly for people with needs that require them to be hospitalized, either seniors or pediatric. I think outpatient care should remain in the different hospitals, easily accessible to neighborhoods. And I also understand you're going to have the answers to the subacute and skilled nursing questions that were raised by the end of this year, or certainly part of the 2015, because that was another thing. But I think all in all, it's very impressive, the goals that have been reached to date.
Commissioner Moore.
I would like to ask Dr. Barnes to finish his points, because I do believe that in order to have a balanced presentation, that his comments as a former physician at St. Luke's would be very important for us to hear.
Thank you.
Thank you very much. As most of you know, on March 12th of 2014, CPMC announced the sudden layoffs of 3 longstanding employees who were full-time, 2 educators, one bilingual, bicultural in Spanish, the other bilingual in Spanish, and its bilingual, bicultural in Spanish administrative assistant. This was in spite of the fact that 2/3 of the patients were and continue to be, to this day, monolingual Spanish-speaking or Spanish as their preferred language. At a recent hearing, Warren Browner, CEO, stated that there were 2 bilingual, bicultural diabetic educators, implying that the problem was being addressed. But what he failed to say is that these educators were bilingual, bicultural Filipinos. And this I understand from talking with people this week. As of Tuesday, there is 1 bilingual, not bicultural diabetes educator who works 1.5 days at the center. There is daily and intensive use of translators, but this is hardly providing the quality of services that bilingual, bicultural educators can provide. What I am painfully led to conclude is that CPMC does not care about the quality of services provided to its Spanish-speaking patients at the St. Luke's Diabetes Center. This, to me, calls into question its commitment to serving minority populations with significant health disparities. We urge the Health Commission to have the Health Department conduct a peer review of the Diabetes Center and not accept the in-house review done by CPMC. Thank you very much for allowing me to speak.
Yes, thank you. And I do thank the Planning Commission for offering the joint meeting to be held here. Our commissioners are probably not as aware as to how to push some of the little buttons. So we're going to use our tradition in asking that each who would like to make comments or ask questions, please raise your hand. I'll recognize that and we'll proceed with our point. Who was Health Commission number 3 that wanted to speak at this point?
Oh, that was me.
Yes, please.
Yes. Are we looking for questions or comments?
Either, just as we would be conducting. So if there are some questions, matter of fact, I'm sorry, I had one question to CPMC because the question came up in terms of the types and ranges of services. What is the intent at St. Luke's for the maternity services? At what level, or will you be continuing those, or would they be transferred also to Cathedral Hill?
All of those services will continue at St. Luke's.
Which is at what level? I'm sorry. Just for our...
It's comprehensive maternity care, including some of our alternative methods of delivery.
Okay, so if there are pediatric complications coming from the newborn, that would then be transferred?
Yes.
Is that the intent for the new hospital?
Yes.
Okay, and is that what we're doing now?
Yes.
Okay, thank you very much. My fellow commissioners, questions? Dr. Painting, please.
First of all, I guess I want to thank again PMC for the large commitment and investment that they're making in the city and the opportunities for jobs and for growth and healthcare opportunities in general. I find on the positive side the community benefits funds and your participation in the San Francisco HIP to be exceptional. $8 million of any community benefit and actually exceeding it by $14 million is, for me, quite significant. I also like the idea that you're continuing to support the Bayview Children's Health Clinic and that your overall total Medi-Cal managed care beneficiaries is above the target. I think these are really great strengths of the efforts and hopefully the continued commitment, to the larger community health needs in San Francisco. With regards to, again, the compliance issues that we were addressing with Ms. Chala's report, I want to say and applaud you. I think this year's report that we hear is a greater improvement than last year. So applaud that. The baseline carity shortfall, although we're just a 2-year rolling average, I understand the efforts that you're making to increase services, and I really like the collaboration that is happening with the department to bring in the health network patients that are, backlogged and receiving services. I think on our side we need to look at how to reduce failure to keep rates. I think that's an efficiency thing, but that your commitment is certainly appreciated. I also like and hopeful for the partnerships with the Tenderloin and St. Anthony's. I do encourage, as some of the community has mentioned, that there be active outreach efforts in the community. Van Ness is a big street. I'm afraid to cross it. I'm worried how many other people may be afraid to cross it as well, even though you're right in the neighborhood. And so then I'm going to just lead with one last thing here, and this is where I'd like to focus, and this issue of cultural competence and of services at St. Luke's continues. So I would like to ask two questions, if I could, from Mr. Meksud. With regards to the cultural competence issues and the community concerns regarding St. Luke's, because that's where I feel most of the persisting concerns are, and they're the same magnitude as last year. They haven't changed too much, even though I know there's been an audit. So with regards to the audit, my understanding is the Department of Public Health sent you a follow-up letter on November 17th, and we haven't heard a response yet. I'd like to know your specific intent to respond to Director Garcia's inquiries regarding your class evaluation at St. Luke's, both in terms of timeline, what you intend to respond to, and again, also maybe if we can even hear it at the Health Commission. I don't think there's even a reason to wait a whole year to be hearing about your follow-up plans. I have one other question after this. So,
certainly, we had hoped actually to have that response to Director Garcia prior to this hearing. With the Thanksgiving holiday, we weren't able to coordinate all the internal resources and voices that we wanted to have in that response, but we expect that we'll have that potentially sometime next week. So we'll have that response to Director Garcia, and then we'll be continuing to work on that class work that includes all our campuses, not just St. Luke's.
And maybe I might ask our Health Commission President and Director Garcia, can we hear it at the Health Commission?
Absolutely.
Before the next year's?
And I did want to note that we are requesting a peer review, which we had originally requested, and we would like to continue that.
Okay. And the second issue then really relates to the community. I mean, it does seem that the community and SFHHJJ has had persistent concerns about, one, the quality of the conversation and the quality of, having the concerns addressed. I know that there was one meeting, I understand, from St. Luke's and the community. Can I ask you what your plan is for further meeting, and perhaps even why do you feel the concerns keep arising, and how might you address this? Because I think having good relationships with the St. Luke's neighboring community and the participating in the participants of the coalition will really be part of your success and something to be proud of. And I would like to encourage you to do that and ask you to maybe think out loud. Why do you think it's happening? What do you think you need to do to maybe address some of the concerns or the relationship?
We share your perspective. I think that's why prior to the actual meeting at the end of August, we had a pre-meeting with some of the members from the coalition, because we wanted to make sure that the public meeting we held would meet some kind of, for lack of a better description, agreed upon expectation that we would not just use that forum in some open-ended way that was going off in a bunch of different directions. We wanted it to be a productive dialogue. So that's why we held kind of that pre-conversation to try and determine what were the things that we wanted to talk about. So we created an agenda for that meeting, and I think, to answer your question, it's to continue that type of approach. And hopefully, as we continue that dialogue, we might better meet the expectations that we're hearing.
So that meeting was in August. Are there further meetings that are already been planned?
We talked about having an additional follow-up meeting in the next 6 to 9 months. We did seem to get to one. We suggested that the topic of that next conversation, again, be focused. It seemed like a lot of the conversation kept coming back to the transportation issue around how some of the populations, you've heard some of the comments today, might have better access or understanding of how care might be coordinated. So we had talked very generally that might be the topic of the next meeting, and we would certainly then ask all the appropriate parties not just from CPMC or the coalition, but from across the city who might weigh in on that topic to be part of that conversation.
And maybe bringing them in as co-participants to help co-agendize this thing. Maybe there's a way that to share even leadership of that meeting that might help facilitate the proceedings. So.
Right.
Okay, well, and then overall, I guess, thank you very much. I mean, I think you guys have made great progress. Again, I would hope that you'll continue to look at this issue with the St. Louis community, and we hope that we'll hear more progress about this over the next coming months. So, thank you.
Commissioners, any other? Dr. Sanchez, please.
Yeah. Thank you. I just wanted to state that I think that I thought it was it gives us a really unique understanding of the challenges of an urban area as we want to maintain some institutions that have provided exceptional service to a very diverse population. And this isn't true just for now. We're going back over 100 years, St. Luke's and other institutions here. And this has really been a challenge. And I think overall, I think we've made some significant headway, even linking the fact we're linking now with St. Anthony's, which has been there for over 100 years, and other areas which have been also changed. Remember, in the Mission, we used to have a number of hospitals before that are no longer there. They moved out to Daly City, and now they're in bankruptcy along with some other ones. So St. Luke's is there. It's sort of been the pillar and a partner with San Francisco General Hospital. I just wanted to make a few observations pertaining to different parts of the section that were brought up. In reference to the workforce, I remember we had discussed this way before about let's take a look at the different populations within the city and what can we do to provide these entry jobs and other jobs. And I mentioned the fact that there used to be a really fantastic Native American training program for our high-rise arc welders. And then we used to have other, through Local 261, the Mission Language Vocational School in the Mission, which has been there over 50 years, since the old Mission Coalition in the 60s was providing job training and so forth for industry and for whatever. And as I read the report and saw there are a number of fantastic options that were developed, there were numerous jobs filled, but I think we could even spread the net even wider, because there are services and programs and unions and training programs, especially as they try and re-gear Voc Ed to really provide some of these services, including training for some of our veterans, and we have many in the Mission and in the Southeast area. The other part that also that hit home quite a bit was some of our seniors mentioning transportation is a big factor, and what can we provide for our seniors who live not maybe in the inner Mission per se, because the Mission has changed. Before, the Mission was all the way from Army Cesar Chavez all the way down to Divisadero. Now it isn't. The Mission split. Mission Dolores isn't part of the Mission as you look at the voting areas and so forth and so on. So all these things have changed and changed and changed. But the quality of service, the training, the linguistic, culturally competent for access, for continuity of care is so critical. All I want to do is say, let's spread the umbrella a little wider. There are transportation services now with some nonprofits, many Spanish-speaking, many serving not only our Latino population, but our Filipino population and our in-service folks who are in-house. And part of that would be, as an example, Central Latino de San Francisco, which has been in operation for over 45 years, which used to be on Potrero and is now by the old Valencia projects, which are now been rebuilt again. And they're on 15th Street, and they have transportation vans, and they've been working quietly under the radar and provide various unique services. The other would be Onlock, which is right off of 30th Street. They have many of the patients there, and they have vans. So, and then there's other programs for seniors in the Excelsior. We work with the Filipino centers in South of Market, et cetera. They have transportation. We work with the VA, so forth and so on. So there's a whole network that perhaps we could take a look at to ensure that any senior, if they need something to go to Van Ness, or if they need something to go to Cesar Chavez program, let's get something done. I was glad one of our colleague commissioners asked Dr. Barnes to finish his comments. Dr. Barnes was one of our first graduates from the community medicine family practice in San Francisco General, UCSF, 35, almost 40 years ago, and volunteered to go to St. Luke's and help set up a program with UCSF and SFGH to develop the family community medicine program. The community medicine part you're very much still active with, which you presented again today, and congratulations on 32 years of excellent service at St. Luke's. But I mean, what we're saying is we have, the concept of a center for excellence. What does that really mean? Well, the populations have changed over time, and we're going to need a real outstanding center of excellence for our seniors, for gerontology. And remember, all med schools and all academic health centers are now required to train and provide some electives and mandated programs for upcoming physicians and health providers for gerontology, for the elderly and the multitude of diseases. What a great opportunity for St. Luke's to expand the network and utilize, quote, partnerships with the multitude of these programs serving seniors in diverse communities, and use this as a real seed to develop a center of excellence at St. Luke's. And you could carry on for another 50 years. Remember, the Bancroft Library is right there on your campus. The original Bancroft Library, which is at University of California, was founded right there. There's a little brick stone still there. Every time you walk by, you think, my gosh, look at the Bancroft now. Well, people are going to be walking by saying, look at the new St. Luke's now over the next 2 and 3 and 4 generations. And I could go on a number of other areas, but again, the quality of care is critical. The training is critical. The due diligence is critical. The fact we have partnerships with the San Francisco Foundation and others is good, but we need communication pertaining to due diligence. Is there a way we could expand the network so we have a core of funds that have already been spent, roughly 2.1 million or something. There was a cohort of 8 million gift. Well, we need to make sure that we expand the umbrella to ensure that nonprofits programs and services are provided. As we looked at the data at San Francisco General, which we just completed, we'll be completing our new hospital there, it was interesting because we spent over $16 million in local small businesses. And we could identify those businesses and the ethnicity and background and gender, et cetera, of these small businesses. And these were unique opportunities. The training programs were also the same. So my question is there any continuity where we could utilize and where we could look at how these small businesses could be provided with, because it'll help build St. Luke's, whether it be the tile, whether it be the artwork, whether it be the plumbing, whether it be carpeting, whatever. I mean, the little stores and so forth. All of these are part of the small business models that were used in the new, quote, flagship of your sister campus, namely San Francisco General, because the two of us, St. Luke's and San Francisco General, are the only two that are still the flagship of open doors and quality care. So we want to maintain that model, and it's important that, again, a dialogue is two-way, and we should take it, and discuss it, and then come out with some consensus, and let's move forward. I think historically the coalition did bring a number of these critical issues to a mandate for both our commissions, and that's why we're here again and again and again. So I know it's a lot of extreme work and challenging work, but we're going to be setting a new model of health care in an urban city that will be second to none. So thank you very much for what you've done. And, we have some other work to do, but it can be done in a positive and constructive way. So thank you.
Commissioner Moore.
I am encouraged about progress, noticeable and metrically traceable progress, both on construction, both projects on time, one ahead of time. The positive comments regarding construction management, which is crucial to all of the discussions we had about impact, both during the EIR as well as the preliminary hearings where there was lack of clarity and lack of a pace of construction. that would suit the community and the neighborhoods. I am happy to hear positive comments about construction management and interface between those immediately adjoining neighbors. What is still a little puzzling and a little bit difficult to hear for me is the credibility of the coalition is with no doubt the driving force of why we are even sitting here jointly and discussing the pros and cons, including being asked to look at the development agreement and commenting on the timeliness of what we hear as the reporting on the development agreement. There are concerns which I almost would label the clash of a corporate culture and a coalition which is basically grassroots and in the trenches. When I hear lack of community engagement, which I would call timely communication, lateness in submitting of report, cultural competency, mix of services where they are needed, I'm saying there is still something not quite in sync, because I think it would be in everybody's interest, particularly in our interest, to have the two groups in sync, challenge each other in a timely manner, that we do not have to sit here and saying, how am I going to be weighing the pros and the cons? I feel kind of like sitting a little bit on an unbalanced balance beam. That's the best way I can describe it. As I recall the Commission's evolving support for particular issues, I go back to cultural competency, and as a woman who requires services, although I am bilingual, I can very well empathize with the difficulties. If you are in a medical situation, no matter what it is, and you do not have somebody who fully understands you, there is no translation which does it. You've got to be able to speak a language with full language competency. And I am a bilingual person, and I know what it means. Otherwise, I wouldn't even be sitting here. And I'm making a strong supportive comment that bilingual competency, not translation, is what is needed in medical care and in provision of services, particularly women-related diabetes and personal issues. The other thing that we have been taking a very strong position on is the support for St. Luke's. And I would like to add a sub-question to the presentation about St. Luke's, which generally is positive. It lacks on the issue of mix of services and on the issue of cultural competency, and that is the interaction or the interface between the medical office building and the commitment that that is an integral part of rebuilding St. Luke's. And I would like to ask a question, which is perhaps not exactly in the agenda, but during the approval of a medical service building on Valencia Street, this particular commission asked for a clearer position on how having a large medical office on Valencia Street would potentially subtract from the commitment that CPMC was to make in rebuilding the medical office building at St. Luke's campus. That wasn't answered then, but I think it goes to the core question about mix of services and accessibility of services in a reasonable radius to where services are needed. That was a question regarding rebuilding of St. Luke's as a very principal question. How do we distribute healthcare services throughout the city? And answers on the medical office building are an integral part of that. Those are my comments at the moment.
Commissioner Wu.
Thank you. So I have a couple of detailed questions, either for staff or CPMC. This is likely for staff. On the timeline of the report, I read that the reason that this errata sheet was handed out was because of a printing error, but there really are substantial changes in the report. And so can staff talk about the timeline for next year and if there might be, the report could come out in full earlier?
So the changes that were made visible following the correction of the printing error have to do largely with information that was already in the CPMC compliance report. Some of them also include some updates that you heard for the 2015 compliance. You're going to hear about those more next year, and we sincerely hope much earlier. With regard to the timing of the city report and this hearing, the timing of this hearing is identical to last year. We had hoped to compress that time, but coordinating the thorough evaluation that we needed to do of CPMC's report did not make that practical this year. And with regard to the review period, the DA includes a requirement for 60 days notice of this hearing, which is the primary venue to consider the CPMC compliance report, and we did provide that notice.
So, do you see room in the timeline for next year to expedite? What is it? Of course, the 60 days is important, and you need the time to review. Where is there room to look at getting here sooner?
Yeah. So one of the things that constrains us is that the DA allows CPMC, I believe it's 150 days. It's about half the year following the end of their reporting period, their calendar year, to submit their report. And obviously, we'd love to work with CPMC to encourage them to make that shorter, but they do have that time in the DA. And then subsequent to that, there's a number of steps that involve coordination of assessment of their report by different city departments, and then collecting those assessments into a single report. We do see some opportunities to compress that a little bit and to hope to get to you maybe a month or two earlier in the cycle next time. We're aware that one of the issues is that we end up reporting, as we did last year, very close to the time that the next calendar year reporting period ends.
Right. Okay. One thing that was helpful that I would encourage for next year, too, was to see what the issues were in the 2013 period and then the 2014 period. It really seems like they are the same issues, and so if we come back for 2015 and see the same issues, I think that is very challenging to continue to say that everything is in compliance. I have some specific questions about the Tenderloin partnership between NEMS and the St. Anthony Clinic. Who is responsible for doing the outreach to find new patients, and how are those people resourced?
So the partnership is with NEMS, between NEMS and St. Anthony's Medical Clinic. NEMS has an existing partnership with CPMC, so this adds another primary care location within the existing partnership. The outreach and education should really come from the partnership, NEMS and St. Anthony's together, and that's why the CPMC Innovation Fund has money in it to do that outreach and education. And I would also say that it's helpful to not have a whole bolus of patients go in at one time, because St. Anthony's hasn't been a Medi-Cal provider before. They do need to ramp up their ability to serve and report in a way that is compliant with state regulations.
Okay, that makes sense, but it was reported that there were only, I think it was either 7 or 14 new patients, and so what's your expectation for the upcoming months and year?
So it was 17 between August and November that enrolled in that time between August and November. And Medi-Cal patients can change their provider at any time, so existing Medi-Cal beneficiaries can be apprised of the new partnership and can choose to change at any time if they would like to.
Okay, thank you. And then for the question on the mix of services at St. Luke's versus the Van Ness Hospital, is that part of the larger public discussion around what services are available at St. Luke's? I heard the CPMC representative talk about transportation. I think transportation is linked to that, because if it's harder to get to Van Ness, it's harder to access those services. Will that be discussed in your upcoming meetings? And is there the possibility to do more frequent meetings, let's say quarterly meetings with the community?
There is certainly the possibility to do more frequent meetings. The line of discussion about trying to develop a service mix with that in that community dialogue is not something that we're pursuing. That's a complicated conversation that goes across all 4 of our campuses. And while we're certainly willing and able to have the conversation with the community about what their needs might be that informs decisions we might be making, it seems challenging, if bordering on unproductive for those decisions for our administration to be making in that manner.
But but you had mentioned earlier that you may talk about transportation and what do you think of then the link between transportation and access to services?
Yeah, we absolutely would like to be part of the solution for transportation in terms of, or I'd expand that to be not just transportation, but the topic of care coordination, and make sure that that dialogue, and as we make decisions about different services, again, that we're kind of meeting the healthcare needs of the community.
Okay, thank you.
Commissioner Richards.
Last year was my first year hearing this, and I think it was the first year that actually came before us. I think there were a lot of issues with the startup of the agreement, getting things in place. I completely understand that. It looked like there was more stuff that was veering on not in complying than in compliance, and I talked about that last year. I agree with Commissioner Wu. I wrote down here, I would love to see progress year to year in a table. I know you have several boxes that you checked, and if you maybe can do this visually, you have not in compliance. That would be a red dot. In compliance, but in progress would be a yellow dot, and in compliance, a green dot. If you could list all these that you had here on your summary sheet, page 3, with year 1, year 2, year 3, and you put your color dots, and you can see over time the progress very, very easily and visually. On a question on the transit subsidy, there was the issue that was raised in the letter from the coalition about waiting 5 years on the transit subsidy. Can you explain why you want to wait 5 years? Employees, please. I have a couple other questions too as well.
Sure, and we have subject matter experts here with us today. This is Janice Hamilton, who is our manager for all of our TDM work.
Great.
Good morning. I'm Janice Hamilton, TDM manager for CPMC, and I came on board in April. It's important to note that we are committed to the transit subsidy beginning in 2017. And the reason for that is there are a sequence of tasks that we need to do between now and the beginning of 2017 to make sure that that transit subsidy is accepted and utilized. We just completed our employee commute survey. Our driver loan rate baseline is 48%. Our transit use is 23%. So what we want to do is we want to look at, if you're looking at a scale, in TDM, parking is an integral part of TDM. So with a scale, if we're looking at parking and driving alone, and we're looking at other commute modes, we want to be able to shift the behavior from driving alone to using commute alternatives. And we want to be able to have stronger disincentives for driving when we implement the transit subsidy. And we're in the process of assessing those things: parking, parking operations, parking management, the cost of parking. We're looking at our shuttle operation. There's great demand to improve the headways on our current shuttle service, primarily from our BART stations, and we are in the process of improving that. So we want to make sure we have these systems in place so that when we come January 2017, that subsidy will be accepted and utilized.
Thank you.
You're welcome.
Commissioner, isn't it also, isn't it also because the 5-year date was simply when the new hospitals open? I think that was the reason for the actual reason that was why there's a 5-year allowance for the transit subsidies.
Where I was leading with this was, I come from a private company I no longer work for, and what they did was they did test cases. So if you thought you wanted to disincent somebody from driving, you took their parking space away and you saw what happened. So you kind of had a little bit of a petri dish. So by the time 2017 comes, you really know what's going to work and what's not going to work, rather than iterate it after the first date. That's really where I was going with this.
Studies show statistically that it takes anywhere from 3 to 5 years to see a shift in a commute behavior. Right.
I agree with you.
We certainly have a lot of work to do, and we're certainly on board to make that happen. So we look forward to offering that subsidy come 2017.
You sound like you know what you're doing. Trust
me.
Thank you. Okay. A couple of other thoughts. I don't want anybody to think that I'm taking away from all the good things, because I actually went through all these and highlighted the ones where you overachieved and there was significant progress. So there was a lot of good work here. We don't have a lot of time. I want to just harp on a couple of things here that one we talked about last year, which was the St. Luke's Diabetes Center and the cultural competency. I remember last year saying, my husband's a nurse, he was in renal care, he doesn't speak Tagalog, he had to have a translator, and the extra actual inefficiency and cost around having two nurses or a translator and a nurse in a room, trying to treat a patient when the person doesn't speak English and my husband doesn't speak English. So I kind of mentioned this last year and said, this seems to be an easy fix. If 2/3 of your patient load doesn't speak English as a first language, why not just have those nurses come back and have them treat the patients? I think it'd actually be better in the end for the care and better in the end for efficiency's sake. You have any comments on that this year? I think I raised that exact issue last year.
So we are, again, completing, we've started the audit of our cultural and linguistic services across all of our campuses, and the operational component of that, which includes staffing and bilingual speaking, we'll have a full report on what our metrics are across the campus. And we've got that information about the St. Luke's Diabetes Center. We presented some of that previously or earlier this year. In a follow-up that we're preparing for Director Garcia, we have also the latest information about the staffing levels at St. Luke's and the Diabetes Center. So that will all be provided to Director Garcia again, likely early next week.
Okay, so that actually things could change as a result of your audit. Okay, I'd really like to understand that as well. Thank you. One more question. So I saw in the visioning on page 8, it looks like you're doing well there. Have you ever had or thought of having a St. Luke's Visioning Advisory Committee? I didn't see one there. Maybe I missed it. Was there one in existence before?
There was community engagement during before the development agreement was approved and signed, and there was conversation then about the services, not just at St. Luke's, but at both campuses, or what would be the remaining CPMC campuses. So there was dialogue that happened along those lines prior to the development agreement even being approved.
Mm-hmm. So as an ongoing, I guess, because you still have these other visioning advisory committees, would you want to establish a St. Luke's?
And the visioning committee, I think you're referring to the visioning committee for the Cal campus?
In Pacific, right.
Right. That is specifically in relation to kind of the evolution of the development of that campus once it's no longer part of our actual operation. And so that's why it's going through kind of that focused, acute visioning process.
So St. Luke's is kind of fully baked?
Yes.
There's no visioning needed. You know what's going to be in there, basically.
Right, exactly.
Okay. Cool. One other thing, real quickly, it seems like we have this kind of more somewhat adversarial relationship, or at least a watchdog relationship between the coalition and CPMC. And I heard several of the speakers say, we want to help, we want to be a part of this, use us, outreach in the Tenderloin to get people to sign up, all this other stuff. What is your thoughts on that? Actually kind of joining forces and coming back with a more powerful impact when you're actually not at odds on things. Where can you actually, do you think, use each other to each other's benefits?
Yeah, and I think this is something that we've talked about, and maybe goes along the lines of the earlier question you asked, but it's the development of formal kind of ongoing community advisory councils for all of CPMC.
Okay.
And I think pursuing actions along those lines might serve us well.
And the coalition will be a part of that?
Correct.
And one last thing, I do want to piggyback on the comment that Commissioner Moore made when we heard the 800 Valencia Street. I believe that was the address. The one of the other CPMC folks, I think Melissa White was here as well, got up and said, hey, we want to, on this Medi-Cal, these underserved populations with the Mission Health, there was a partnership they were going to pursue. I really strongly encourage that to continue to happen. It actually could help these numbers a lot better.
And it will. And I think to answer the Commissioner's question, CPMC's perspective of the 899 Valencia development from SPMF is viewed as additive to the medical care we feel is needed as support for the work that will be done at the new hospital at St. Luke's.
Okay, great, thanks. One last question for Mr. Welch.
Commissioners, if I could interrupt 1 second, wonder if I could ask you to speak more closely into the mics.
I'm sorry.
I'm not getting a lot of the dialogue.
I'm sorry. Mr. Welch, I asked the
Commissioner.
question. I asked the question of CPMC about future role for the coalition. You mentioned something about working together contractually.
Right.
Can you comment on what I heard?
Well, thank you very much for your question, and thank you for asking me to comment on it. The history has not been good. The dialogue that happened before the development agreement was ended by CPMC. CPMC felt it was not productive to continue these conversations on uses of the two campuses at that time. Why, I have no idea. The people that were involved in that process are no longer employed by CPMC. The reality is that what we've been offered at St. Luke's is basically a PowerPoint presentation, which is not quite what we have in mind. There's a long history of members of the coalition involved in keeping St. Luke's open, and keeping it open and a viable healthcare facility in the southeast part of the city. We're very interested in that dialogue, and what I heard today was that is not what CPMC wants to do. They really don't want to talk about what kinds of uses, what kinds of services should be offered at St. Luke's, because it's very complex. And we agree, we understand that, but I think that's what we're kind of looking at.
Sure. So a community advisory committee, I guess it is.
That would be great, but it's the history of community advisory committees in this city is not outstanding. What we would love to and have asked for consistently is a formal agreement with city departments, with the health department and with the planning department. That's where it seems to me CPMC and the development agreement gives the authority to actually recommend compliance. If CPMC, we're more than happy to meet with CPMC in a meaningful way, but what I heard today was that they're not interested in that kind of a conversation. And I would hope I heard the exact opposite from the Health Commission, that they are interested in having that conversation. And so I guess the most fruitful way to have that conversation is with the Health Commission and with the Planning Commission, because CPMC is not interested in having that conversation with us.
Thank you. Mr. CPMC, raise your hand. I'd love to have a response to Mr. Welch.
I would just like to remind that the services that will be provided at both of the new campuses are listed in the development agreement. That they've been in there since it was approved.
Okay. I look forward next year this time to hearing how the community advisory works and have Mr. Welch come up and talk and have you come up and talk. Because I think something can happen when you sit down and actually talk to each other.
Okay, thank you.
Thank you.
Commissioner Karsner, please.
Just a quick comment. I know we're out of time, but this whole issue about information and information sharing and timeliness of it, I think that it is really important that that be ongoing as opposed to just periodic at the end of a time, and that if people were, whether it's the coalition or whether it's the commissions, have ongoing updates, it may not be the analyses, the ongoing updates of what's happening, what's not happening, and then also use that as the forum for whether it's an advisory board or whether it's these opportunities for the community to have conversation, not just yearly, but ongoing, could go a long way to address some of these issues.
Mm-hmm.
Commissioner Antonini.
Yeah, for a gentleman from Cal Pacific, just one more question just to clarify things, because I know there's a certain amount of confusion. From what I understand, you're going to have medical office buildings at both St. Luke's and at the Van Ness Cathedral Hill location. Correct. And probably there is one or will be one at Davies, too, I would think. And I would expect a broad range of services, outpatient services are available in all of those facilities.
Correct.
So people who live in those areas and are ambulatory and it's an outpatient service would go there. But if you're hospitalized, and understandably, neurologic would probably be at Davies.
Correct.
Pediatric care would probably be at Cathedral, and, so it only makes sense that you're not going to duplicate all these different services at each of your 3 hospitals.
That's
so
correct.
That's kind of what I'm hearing from you, but I think that clarifies things a little bit.
That is correct, and I do, again, believe that that's specified in the development agreement.
Yeah, I remember reading all those different services, and, it sounds like it's moving in the right direction.
Correct.
I'd answer most of the concerns about transportation, because the hospitalized patient isn't traveling very far. I mean, when they're in the hospital, it might be, visitors would have to come from another area, but the hospitalized patient stays there until they're released.
Exactly, or parents of children.
Yeah,
so
parents of children.
Exactly.
Yeah, and you still will have, as you said, routine maternity services at St. Luke's for not at-risk births and even care of mothers and children after birth for whatever period of time they'll stay in the hospital.
Correct.
Thank you.
Yes, from the Health Commission side, I believe that you've heard that we have concerns in regards to areas that are shared with the Planning Commission. Clearly, we have moved forward from last year, although some outstanding issues regrettably remain. I would like to commend CPMC for actually taking on the issue of both subacute and the SNF and creating that committee that we have looked for several years, and we really look forward at the Commission to understanding a possible solution for this city and for this community and for perhaps the region in regards to both subacute and SNF issues. So I think definitely CPMC should be thanked for taking that initiative that we had hoped it would take at our last meeting here. Likewise, the work that they have done in regards to come into compliance in regards to units of service and the levels certainly have come into the agreement parameters and beyond. And the ability to work with our San Francisco Health Network and helping with the safety net services are all positive in terms of the community benefit that we're all going to be getting from a strong CPMC and St. Luke's. I think the areas, though, that we remain very concerned about are quite well outlined by Dr. Garcia and are not just simply for a compliance issue in class. Definitely what you have submitted to us would pass the Joint Commission. But that isn't really what we're about. We're about whether or not that really passes the measure of helping our patients. That's what class is, and I think you've heard from both sides here, from both commissions, a real concern that we've got to be sure that there is cultural and linguistic opportunities that are afforded to both our patients and for our delivery service. And I think that is a very important issue. It's been pending now for at least 2 years, because it's taken us another year to get to this point in the report. And I would hope, like our fellow commissioners have said, that we're able to put a green light on that one, and that there's truly a cultural and linguistic program that is meaningful and not merely one that meets certain standards of participation. But that it really is and has that imprimatur from both an outside source looking to see whether the program that has been developed makes sense, and particularly where patients and those who are using it can tell us that it is of use. I really think that's where our letter went for that understanding. I believe that the same as a subnote relates to the entire issue of which the St. Luke's Diabetes Clinic is merely a symptom. And that it's not just the St. Luke's Clinic that we're concerned about, but any of our other clinics that both St. Luke's and the Cathedral Hill campus would have the ability to respond to that. It's taken way too long, unfortunately, as we are trying to help with our patient care even today and not waiting for a new hospital to understand how cultural competency and the ability to answer those issues. And I believe that, as Director Garcia said, that we would like to see that report coming to the Commission before we even need to have another joint conference meeting here. So I think those are areas in which the Commission will continue to work in partnership. It's been a, I think, productive partnership this coming year. I'm pleased that the staff has felt that it was important to highlight what was happening even outside of the official agreement report here, which ends a year previous, but that you've been able to show the progress that has been made in this year particularly. And if we continue that ascent, both in employment and working with the community and answering the issues of competency of services, I would imagine that by next year at this time, I think we expect to see greens on all of our points. Great. So I thank the parties for actually being able to continue to work through this process in the coming year, and I really encourage that even more progress be made so that we will have a first-class facility, a first-class service that adds to the enormous wealth of services that we will be able to offer our residents. Thank you.
Commissioner Richards.
No, he summed it up. I'd love to see a copy of the audit that you mentioned when it's done. Thank you.
Thank you.
If I may, Commissioners, Director Garcia of the Health Department, the one concern, and I think a piece of advice I would give to CPMC is in this new world of competitiveness for patients being able to make decisions of where they're going. It's going to be really important that you have an open ear to the community. As someone who's being told by community what to do every day, I have to tell you that many times I get great ideas from the community and patient input. It makes us a stronger department, it makes us a more culturally relevant department, and it makes us also a quality improved organization. And so it's really important as you work with community and coalitions who are very strong in San Francisco. You're not in any Kansas. You are in San Francisco. And San Francisco has a very strong community input. So I would really advise you for the future to just listen, acknowledge. People here know they can't direct the corporation to where they're going. But it's very important for you to hear them, to listen, and I can guarantee you, you will get some great ideas of how to be more patient-centered and improve your quality of care for the future of San Franciscans. And I just encourage you to do that a little bit more, because your language today can be changed a little bit to make community feel much better and heard in terms they understand, they know the community, and you would do really well by just being a little bit more open to hearing them and trying to make this divide a little bit smaller in terms of really understanding the needs of the community. I think CPMC and Sutter would do so much better in this process. And we've been here now going on many years, and I've started my career with this development agreement, and I think I would continue with it throughout my career. So I just really encourage you to a little bit more humility and some humbleness in terms of how you approach community input. That's my advice for today for you.
Okay. If nothing further, this meeting is adjourned. The regular Planning Commission will resume in about half an hour, 45 minutes.